for decades, we know that the standard treatment for seminoma really hasn't changed for stage 2 seminoma specifically, and it's been either radiation or chemotherapy. However, in non-seminomas, we have surgery as an option, RPLND, for early metastatic non-seminomas. So I got to thinking a few years ago when I had a small volume stage 2A seminoma, thinking, why do we treat this the same way we treat widely metastatic disease with either 3 cycles of BEP or 4 cycles of EP or radiotherapy? Why don't we offer regional therapy, i.e. surgery? So with informed consent and a lot of discussion, we went forward and started treating some of these patients and published our first 4 patients as a series. And none of them had recurrence, went very well, straightforward operation, and really avoided the toxicities. So I thought really to move the needle and bring this into sort of the armamentarium, we need to have a paradigm shift here and be able to show these results in a bigger trial. And so that's what led to the idea of a multi-institutional phase 2 trial. Obviously, we couldn't do a randomized trial because it would take decades to compare to the late side effects of chemo and radiation. We started with interested centers and centers that we know do a lot of surgery and see a lot of germ cell cancer patients. There had to be a vetting of the surgeons on the trial. They have to be experienced surgeons, having done more than 8 RPLNDs per year or 24 in 3 years. So then we picked the sites, we picked the surgeons, and basically on a rolling basis, they started opening and putting on trials. The inclusion criteria was any patient with early stage 2 seminoma. So any retroperitoneal lymph node less than 3 centimeters and no more than 2 lymph nodes. It was met with enthusiasm from the very beginning because, again, we were doing this more or less for stage 2 non-seminoma. So it made perfect sense. We didn't have to alter anything. It was the sort of same principles. We just had to start collecting data prospectively, which is something we had not done as a group in a long time. In fact, ever, at least in my span of my career. So that was also great to get everybody involved and start collecting data prospectively, both on recurrence, this is a surgical trial after all, so complication rates, length of stay, and things like that. The original statistical analysis called for accrual of 44 patients, and towards the end of the trial, we were doing so well, so we increased it to actually 55, just to have more patients on the trial. And we found that 18% of the patients had a recurrence, meaning 82% of the patients were cured by the surgery and did not require any further therapy. One patient was treated with adjuvant chemotherapy, but the point here was to prove that surgery can be curative in many of these patients, or most of these patients, without any further therapy. And that's what we showed. Our original hypothesis was that the surgery would be 70% effective, and it was more than 80% effective, at least in a median of 24-month follow-up. There were 20% of the patients had recurrence, all of whom were cured with either subsequent surgery to patients or chemotherapy, which is the standard. So this is a therapy that has the safety net of chemotherapy for those who relapse as well, as we do again in non-seminomas. So again, if you offer surgery to patients, then we can tell them, look, we think this is going to be at least 70 to 80% effective in controlling the disease, and really be able to avoid the long-term toxicities that come with chemotherapy and radiation therapy in a very young population. Well, I think, even though this is a phase 2 trial, I think it really establishes RPLND as an alternative treatment. It should be competitive up there in the guidelines in terms of treatment of early stage seminomas. We're still learning about the boundaries of who to treat. We picked 3 centimeters as our lower end of our spectrum of metastatic disease because we know clinical staging often understages the disease. And if you think you have 2 lymph nodes, you'll end up with 6 or 7 lymph nodes. Or if you have more than 2 lymph nodes, you end up with far more than that. So we wanted to limit it to stage 2A and early 2B. And we're still learning the pathological nuances of those who relapse. We're still working to get additional data. But again, I think what we've learned, at least so far, is patients do very well. This is an operation that, at least in my center, is associated with a 1-day hospital stay, small incision, very straightforward for experienced surgeons to do, and really hope to offer a long-term cure for patients who otherwise would have had systemic therapy. Yeah, next steps are longer follow-up. So the secondary objectives were 5-year recurrence-free survival. Generally, in testis cancer, as many experts know, we have most of our events early on, typically within a year to 2 years. So we think we've captured enough, that hence the primary objective being the RFS in 2 years. But nevertheless, we're going to follow up these patients and see, of the ones who relapsed, where they relapsed, and how they were treated, and make sure that they were disease-free subsequent to that. I think really the next phase and the next step in further investigation is incorporation of microRNA. One of the things that we knew we would highlight and discover in this trial would be the patients whom we thought had metastatic lymph nodes, but turned out not to have it, so PN zeros. And we know that from non-seminomas, where everything points towards a metastatic lymph node, and then you do the RPLND and the patient has benign lymph nodes. So we found this in this trial as well, and about 20 or 25% of the patients had actually benign nodes. Those same patients would have been treated with either chemotherapy or radiation therapy. So again, we think that in those cases, the surgery served as a nice diagnostic tool and be able to adequately stage the patient so they don't get any further treatment down the line. And because of seminomas, we don't think it skips the retroperitoneum that goes to the chest, so it has implications on follow-up. So I think, in the future, we'll come up with guidelines as to, if you have a negative retroperitoneum, this is how you should follow the patient. And if you have a positive retroperitoneum, we'll see the patterns of relapse, the timing of relapse, which has implications on imaging, both modality and also imaging frequency. I mentioned microRNA 371. We know that has incredible high fidelity in being able to detect active germ cell tumors. So in these equivocal cases where we have a 1 centimeter or 1.5 centimeter retroperitoneal lymph node, there's no rush to start treatment in those patients. I think one thing we want to do is measure microRNA 371, and if it's negative, have a period of observation. So we're working on those next set of trials to incorporate biomarkers that we know for the past 10 years, a lot of work's been done to delineate these markers and their utility in this setting. I just want to thank my collaborators and all the people who worked on it with me. This is obviously not a one-handed effort, and everybody, it's the whole community coming together to put this together. And again, in the next set of trials, we hope that not only nationally people will get on, but also internationally. I think germ cell tumors are a rare disease, and this is a rare sort of stage that many see. So I think we do need international collaboration. So we hope that our partners in the UK and Germany and Canada will join us in the next effort.